Good evening, sir.
Good evening, good evening. Today there is an interesting case.
Okay, sir.
Okay. After the initial short case, we'll start.
Sir, you can start the session.
Yeah, in 1 minute's time we'll start. Just 1 minute. Okay, we'll start the session. So good evening to all of you. As usual, I will start with a short case first. Is my screen seen?
Yes, sir.
Okay. So this case is actually given to me by Dr. Samya. This is a story of a 40-year-old chronic alcoholic male with no known comorbidity, manual labor by profession, presented with sudden onset of altered sensorium followed by cortiparesis. Weaknesses more on the left side. This is a short case. Look at the video of the patient. This is the video.
ডান দিকে তাকাও তো
I'm looking down.
বাঁ দিকে তাকাও
The right and left.
আবার ডান দিকে তাকাও
The right.
উপরে তাকাও
Up.
নিচে তাকাও নিচে 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 উপরে তাকাও নিচে তাকাও দাঁত দেখাও তো বড় করে দাঁত দেখাও
Ask you to
জিভ
show the
বার করো
teeth.
বড় করে বার করো মুখটা ফোলাও
Ask you to blow the cheek. Okay, I'll show the video once again.
বড় করে তাকাও
Open the eyelid. You're unable to.
ডান দিকে তাকাও তো
It's a primary position. Looking
বাঁ দিকে
down.
তাকাও আবার ডান দিকে
Look at the
তাকাও
left side, right side.
উপরে তাকাও
Up,
নিচে তাকাও নিচে নিচে নিচে
down,
উপরে তাকাও
up.
নিচে তাকাও দাঁত দেখাও তো বড় করে দাঁত দেখাও
Show the teeth.
জিভ বার করো
Putting out the tongue.
বড় করে বার করো মুখটা ফোলাও
Okay. So what did you find in the ocular examination? Where is a localization from the eye movements?
Left ocular motor palsy complete.
Only left ocular motor? What about the right eye? You
No,
want to
the
see
right
the
eye,
video?
right eye, there, my lateral
Pardon?
rectus was facial, sir.
Yeah. So what all the muscles are, I mean, cranial nerves are affected or muscles are affected, what is a localization?
Likely in the pons.
Pons, okay, but yes, good. Okay, where exactly what structures are affected? Is the third nerve or a sixth nerve or a gaze palsy? What is your, that's the thing I like to know.
Can you show the video again?
Yeah, I'll show the video.
Right.
Definitely I'll show the video. No,
বড় করে তাকাও
bilateral
ডান
ptosis.
দিকে তাকাও তো
King,
বাঁ দিকে তাকাও
left,
আবার ডান দিকে তাকাও
right,
উপরে তাকাও
up,
নিচে তাকাও নিচে 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 উপরে তাকাও নিচে তাকাও দাঁত দেখাও তো বড় করে দাঁত দেখাও
that is regarding
জিভ
the,
বার করো
Left midbrain.
no, around the localization, right, findings.
So left complete third nerve, left ptosis, right gaze, bilateral up gaze.
Okay. Right.
Is there
Any
a
other?
So even horizontal gaze is restricted, sir.
Pardon?
Say without you. Okay.
Horizontal
Pardon?
gaze is also restricted, sir.
Okay, horizontal gaze is also affected. Agreed. Then
Complete as a further examination is needed, but definitely there is lower motor neuron type of affection of the bilateral third nerve, but right
okay.
side of adduction involvement is also there. So some gaze pulse is also there. Could be
Right.
a
So,
junction or a brainstem.
okay. So the answer I wanted was bilateral third nerve. Why bilateral third nerve? It's got a bilateral ptosis, obviously left more than the right. So that tells you that a ptosis cannot occur with a gaze palsy. If ptosis is there, it has to be a third nerve. So as the subsequent movements also tell you that the left eye is moving less compared to the right side or looking up. And his abduction also restricted both sides. Okay, I'll show the video once again now. Yes,
তাকাও।
bilateral ptosis,
ডান দিকে তাকাও তো,
looking down.
বাঁ দিকে তাকাও,
Left is
আবার
incomplete,
ডান দিকে তাকাও,
right is incomplete,
ওপরে তাকাও,
up is
নিচে তাকাও,
incomplete,
নিচে
left is
নিচে
more
নিচে,
incomplete than the right.
ওপরে তাকাও, নিচে তাকাও, দাঁত দেখাও তো বড় করে, দাঁত দেখাও,
Okay, so he's got a bilateral
জিভ বার
third.
করো, বড় করে বার করো, মুখটা ফোলাও।
So he's got bilateral third now. What else is there? Because he has got a failure of full abduction on the right, both sides. So that could be either a lateral gaze palsy bilaterally, or it could be to sixth nerve palsy. Both are possible, no?
Yes.
It
Yeah.
can be the medial part of the left midbrain only, which can
Left
actually
facial weakness
left
is
midbrain.
also there.
Facial weakness is there. That I agree with you. I'm not talking about the ocular movements. See, the ocular movement, gaze got a right there now also. The ptosis is there on the right side.
You can do a
Oh.
vestibular reflex and see.
Correct. Right. So the question now is, the answer, one point is clear, is got a bilateral there now. What is the failure of abduction? Is it due to the gaze palsy or is it due to the bilateral darkness? The answer is what Joy has said. You have to do a ocular cephalic reflex. If it is a midbrain lesion causing bilateral lateral gaze paresis, the ocular cephalic should be intact. On the other hand, if the sixth nerve nucleus or abducens nuclear complex is affected, ocular cephalic will be absent. Okay, that's the answer I want. Okay.
বড় করে তাকাও।
So, yeah, any questions? The gaze palsy is because midbrain lesion. Gaze palsy is because of the involvement of the descending frontomesencephalic fibers, which ultimately go to the PPR. Okay, right. So, this is the thing which you already discussed. The most likely lesion is because single site, you have to think of a midbrain lesion. So more likely the abduction field is due to bilateral lateral disc palsy due to the affection of the descending frontomesencephalic. Just let me examine it. So this is the what test to differentiate ocular cephalic. In fact, that was not done. First of the findings I will show you.
ডান পা নাড়াও, বাঁ পা নাড়াও,
Is not
ডান
able to
হাতটা
move
তোলো,
both the lower limbs, able to move the right
বাঁ
upper limb.
হাতটা তোলো, বাঁ হাতটা তোলো,
Left upper limb is more weak compared to the right side. So the corticoparesis mainly on the more weakness on the left side. So this is the MRI. See what is happening to the lesions in the pons as well as in the midbrain. It is affecting both sides here. And the anterior part of the pons also is affected.
What about more upper sections like the not Cossacco cycle?
Well, in fact, this is the only midbrain section is available. Other is only this is only sent by Dr. Samia. This is only available picture I am showing. Let me see other picture. This is the only film which is sent. Anyway, the thing is that in fact, likely to be in the bilateral third nerve plus he has got a lateral gaze palsy. That's a localization. Could be, if you ask me why not lateral rectus, it's possible since we are not done an ocular cephalic reflex.
So clinically we can consider myoneural also, sir.
Yeah, if we are only shown the eye movement alone, that's a good possibility. Definitely minor junction possibility should come. But in minor junction disease, ocular cephalic reflex will be normal and it will be absent. That is not like a gaze palsy.
Okay.
Okay, now shall I go to the next case?
Yes, yes, sir.
Yeah, this is a long case. You have to have a close watch on the video and the findings. This is a 65-year-old man, a case of progressive weakness of both lower limbs. His complaint started as weakness of toes in the left foot 2 years back. Subsequently, over a few weeks, the same weakness occurred in the right foot. Subsequently, the weakness progressed in the form of climbing stairs and difficulty in walking after about 4 to 5 months' time. 1 year back, he was still walking with the support of the walls. For the last 6 to 8 months, he was walking with the help of a walker. He became bedridden for the last 3 months. So progressive weakness of both the lower limb. First started the left foot. About 6 to 8 months after the onset of the weakness, nearly 1.5 months, years back, he noticed numbness of both the lower limb. He could not say whether it started distally or proximally. He said numbness, he is pointing to the thigh, that's all. On leading question, he was asked about the bladder problem. He said he has got a thin urinary stream for the last 1 month. No complaints pertaining to the upper limbs or cranial nerves. Okay, so I'll go back to the history once again. Progressive weakness in lower limbs first started in the left foot, then right foot, then gradually ascended up, producing difficulty in walking, which gradually worsened, which made the patient bedridden over a period of 1.5 years' time. About 6 months after the onset of the initial weakness, he had numbness of the lower limb and thin urinary stream for the last 1 month. That is one leading question. No complaints pertaining to the upper limbs or cranial nerves. So this is the video of the patient. Cranial nerves were normal, so I am not showing that thing. Upper limb tone was normal, power was also normal. Deltoid normal, triceps normal. Small muscles upper limbs are also normal. Is found to have a Weaver's sign. And the lower limb I found mildly wasting on the both quadriceps. The calf muscles were normal, but zero power of all the muscles. Reflex in the upper limbs normal. Lower limb, both knee and ankle joints are absent. Plantar was mute. Abdominal reflex are absent both upper and lower quadrants. And check the Weaver's sign is upper, but they could palpation lower abdominal muscles contracting, but we had a positive Weaver's sign. Test sensation is normal in the abdomen, absent in the lower limb. He said yes. There he is not able to feel. There he is able to feel. He'll tell you when it is able to feel the sensation. There he is, the mid upper thigh is able to feel. There he is able to feel the pain. Vibration is normal in the upper limb, absent in the lower limb. Antidisciplinary leg pain is absent. On the back, he said he is able to feel there. There he is able to feel. L5 spine able to feel. In the sacrum also he is able to feel. Joint positions normal in the upper limb.
അനങ്ങുന്നേ അറിയുന്നില്ല. ഇതും അനങ്ങുന്നില്ല.
Even the angle jack movement also is absent in the lower.
കാല് നേരെ പൊക്കിക്കോ.
SLR was negative. Okay, so these are the findings. I think I will show the finding once again in the lower limb. That is very important. Sorry, power testing.
വെരി ഗുഡ് അതുപോലെ പിടിച്ചേ. മതി വിട്ടോ.
They are unable to move at all. Rotating the hip only a little bit. That's all zero power. Then reflexes, I think, let's keep, upper limbs normal, lower limb absent. Sensation, the sensory level, there was pain level at the mid thigh. Vibration joint sensor all impaired in the lower limb. Absent abdominals.
ഒന്നുകൂടെ പൊക്കിക്ക്. മതി വിട്ടോ. ഒന്നുകൂടെ മതി.
That, I think I'll skip that thing. Okay, that's a pain. That is normal. It's able to feel the vibration over the back up to the sacrum. JP is lost in the lower limb. So I check the vibration. This is the wasting of the thigh, but calf muscles appear normal. Not much of a wasting. So cranius normal, motor, tone power normal in the upper limbs. Weaver sign was positive. Lower limbs wasting of both thigh. No wasting of the calf or entry compartment muscles. Grade 0 power of all four lower limb muscles, except for mild rotation is possible. Normal in DTR, normal in the upper limb. Both knee and ankle jacks were absent. Abdominal reflex absent in both quadrants. Plantar mute. Sensory system, all sensations are lost below the inguinal region. So where is the localization? So I'll give you pardon?
Myeloradiculopathy.
Myeloradiculopathy. Good, very good. We've got a but what is also myelopathy here?
At a sensory level.
Yeah, the sensory level, that's in the thigh only.
And even the it's not okay.
Sir, it's basically if we just analyze in that way, that this gentleman is presented with a subacute to chronic onset asymmetric paraparesis of flaccid lower motor neuron type.
Yeah,
that is the basic thing with started with the motor component first, followed by sensory component.
Sensory, correct.
Along with some amount of recent development of an urinary problem.
Yeah, right. That's only recent, correct.
And having a L1 level or something like that. In thigh level, there is a sensory level and the mid thigh.
With the L1 somewhere around L2.
With a positive Weaver sign.
Correct.
And absent of the abdominal reflexes. So
right. Abdominal reflexes absent both above and below. Yeah.
Above and below. So if the abdominal reflexes are lost from above and below, so T8, T9 level, we can think about the dermatomal level of the T8 and T9 because of the positivity of the Weaver sign. So what would be asymmetric onset? This type of problem, if we face, most likely the lesion will be in the spinal cord level and or the root level.
Okay, my question is it a cord lesion or is it radiculopathy or a both?
But if you look at radiculopathy also, but maybe there's also a cord involvement because the bladder sensation is, the bladder is involved, could be because part of the radicals also.
Yeah, that can be part of radiculopathy also.
So
it radiculopathy and don't be surprised there's a myelin involvement. Myelin involvement is
Maybe both, sir, because of motor followed by sensory, the pattern, no, sir.
Yeah.
No,
Maybe
see, the problem is, okay, any element lesion also, caudicon also can occur in the lower limb. Human also can present like that. Pattern is not going to help us here. But with the concrete findings, he has got areflexia, hypotonia, zero power. Okay, sensory level below mid thigh. It can be extensive caudicon lesion. The only point is that caudicon lesion cannot explain the lower abdominal muscle weakness. That can be explained if there are radiculopathy. Suppose imagine a meningitis causing caudicon lesion. Then meningeal inflammation ascend upward and involve the lower dorsal roots also. Yeah, that also can put it. That would also affect means you can lower these things also possible. Okay, or you can think other way around also. Need not necessarily be a caudicon lesion. See, any root lesion can be due to a segmental lesion also. Suppose imagine a cord lesion from the epicornus, cornus, or going up to the ascending up to the dorsal cord, long extensive lesion, intramedullary can produce the same thing. You can't differentiate an intramedullary lesion on the epicornus cornus from a caudicon lesion at all. Only the upgoing bladder is present, of course you can. Otherwise, you can't differentiate. There can be that possibility also.
Yes, sir.
Yeah, that's also possible. But another possibility you think is a myelopathy, and radiculopathy is more severe, so that the myelopathy symptoms are masked. Okay, that kind of thing, but no hard signs of any myelopathies. Agreed? Okay. Right. So what is LM? Is it LM paralysis, spinal cord? A pure spinal cord lesion is very unlikely. It can't be a spinal shock lasting for 2 years. Okay. How can a spinal shock persist for 2 years? So that is pure spinal cord lesion is unlikely. The point second is expected wasting of the thigh, and he has been bedridden for 3 months with bladder, but bladder problems came only for the last 1 month. These are all against the cord lesion.
It's not, I mean, you said spinal cord lesion, epicornus to cornus to dorsal cord, no?
Yeah, correct.
That's a spinal cord only.
I don't know what I meant that when you say myelopathy, I'm talking about a myelopathy, the pyramidal lesion. When you say myelopathy, you usually refer to the lesion upper motor neuron. What I meant was it's not a pure upper motor neuron lesion, not element type.
Okay, sir.
Okay.
For
There's
an
something like
intramedullary lesion, sir, there is no dissociated sensory loss. No? Sensory loss there is no dissociation, no sensory loss is only
that depends upon the extent. Suppose the intramedullary lesion happens to involve the dorsal column also. See, the dissociation all applicable only a lesion confined to the central gray matter. Okay, when it expands outward into the dorsal column, posterior column also will be lost. Say, for example, a tumor. We are not thinking in terms of a syringomelia-like thing. A tumor can start anywhere in the cord. Need not necessarily be from the central part. Intramedullary means inside the cord. Then maybe the posterior column, maybe the lateral column, maybe the central column, wherever it is can start. Extramedullary means coming from compressing outside. Because why I thought not extramedullary is also possible. If, for example, lesion extending from D10 down up to the caudicon, that's what I said, meningeal lesion, which involving the lower roots around the cord, compressing the cord, lower part of the cord, as well as the root possible. There it becomes an extramedullary, a meningeal compression, say like a arachnoiditis or something like that. Or it could be lesion tumor inside the cord. Both are possible. So this is what you should consider: intramedullary lesion extending D10 up to the cornus, or a meningeal lesion affecting all the roots plus the roots surrounding the cornus epicornus region up to D10. That's also theoretically possible.
Sir, is it possible to have an intramedullary lesion that is affecting the anterior horn cells and then extending posteriorly? Because there is a discrepancy in the muscle wasting. The thigh muscles are wasted, and you kept on repeatedly saying that the anterior compartment muscles are not wasted.
Correct. What you said is correct. That's correct.
Suppose that L5S1 area, the anterior horn cells are not involved.
Not involved. Or maybe involved to a less extent.
To a less extent, and it is extending and involving the bladder recently,
That is,
S2,
right. So that see, if your argument is correct, the maximal least may be at the L34 affecting the cordyceps and all. Why there is no wasting? Either the root lesion is very minimal, or there may be myelopathy component causing that thing. But the radiculopathy is causing the reflex loss, and the weakness may be human. That also you can argue. Okay.
What if there is a lesion in the cord that is involving the root entry zone as well, and which is causing a reflex loss?
That can result in reflex loss. Perfectly correct. That need not necessarily produce when wasting and weakness. Reflex loss can occur due to root entry zone involvement. In fact, last class I told you, the earliest evidence of intravenous lesion is only reflex loss. Because suppose the reflex, the dorsal root ganglion, the reflex fibers go through the intramedullary component, synapse with the anterior cells. See, if it is between the dorsal root entry zone and the anterior cell is the lesion, only reflex will be lost. Sensation will be spared because the posterior fibers already escaped. Motor fibers will be spared because the anterior cell is not affected. That reflex loss can be the earliest point. So that's also possible.
So then do we have to bring in a radiculopathy?
Why radiculopathy can explain by the anterior cell also? The weakness you have in the thigh weakness can be due to the anterior cell loss, intramedullary producing anterior cell loss. So you can think that why the calf muscles are affected. You cannot straight away say anterior cell, not much of a wasting, but essentially looks like an element. Okay, is it clear to you? So it could be, you can argue that maybe a myelopathy component causing the weakness of the calf. That's why you're not getting a wasting that much of as a thigh. Okay. Any doubts in that? Okay. Now let us see. Or is it atypical CADP? That's another question. Because it's got pure element finding can go anywhere, in any part can be affected. Okay. So the patient came with the following investigations done in the previous hospitals. The whole MRI screening was done. That is about 2 years back. 1.5 years back. It only shows posterior disc oscopy C566 L4 L5. MRI brain was also done. Mild age-related atrophy. Then first NCS was done in September 2022. That is NCS finding. Upper limbs normal. Lower limb you find decreased EMF amplitude from the both peroneal, EDB. And however, the amplitude from the tibial was normal, but there is some prolonged conduction velocity in both the tibial. Okay. Then this is F-wave latency is prolonged in both the tibial and deperoneal, the lower limb. Sensory potentials were normal. This is the first NCS. This is done, first NCS was done in September. I will tell once again. The amplitude was decreased and the conduction velocity is prolonged in the tibial where the amplitude was normal. F-wave latency is prolonged. Then second, this thing is...
What about sensory?
Sensory, no, I showed you, sensory potentials were normal. This is sensory potential. Whatever abnormality is there, I will mark with a red circle. So that easily to understand. The second NCS, again was done after 3 months. Again, the motor conduction was normal. Then the lower limb findings again, both deep peroneal amplitude is low. The conduction velocity is also same, decreased velocity. Not much, mild decrease in the velocity. F-wave latency is deep peroneal is one side is not recordable, other side is prolonged. However, the tibial subsequently was done seems to be normal. Previously, it was prolonged. So this was the NCS finding. Again, the sensory potentials were normal. So What do you think from the out to the NCS? I'll come in just 1 minute. In just 1 minute, I'll come. By the time you can eat. Okay. What do you want now at this point of time?
Cyclical radiculopathy.
Okay. It can be radiculopathy, but they say conduction velocity seems little prolonged. Anyway, let us see. So then other investigations done from outside. They did a myeloma workup. The myeloma band was detected. And this is the electrophoresis. There is a myeloma band. M spike. Also the other investigations as well.
Excuse me, sir.
Pardon? Couldn't you see?
Sir, one doubt, sir.
Yeah.
So NCS, where should we localize, sir? Because sensory you can't explain, no, sir.
No, you're perfectly right. If the sensory is preserved and motor amplitude is decreased, you have to localize due to the preganglionic lesion for sensory. That means this points to a radiculopathy, a quadricular lesion, or a segmental involvement in the spinal cord, causing the decreased EMF amplitude. Fragmentary constant involvement also put a decreased EMF amplitude, but the sensory pattern will be normal. Same with root also the same. Motor root can produce decrease EMF amplitude, but sensory root will not produce a snap abnormality because it is preganglionic. So with this finding, you have to think of a lesion either in the chorda equina or in the cord.
But the MRI was normal, no?
Pardon? MRI, that's a report given. And second, but the only thing is in those sites, but you won't get a prolonged conduction velocity. See, if you got a sensory potential can be normal, the sensory, the velocity is increase in that shows the peripheral lesion. See, if it's a radiculopathy producing, say, let's take motor radiculopathy is affecting in the chorda equina. You can have a decreased EMF amplitude, but you cannot have a prolonged conduction velocity because that shows the demyelination in the peripheral part.
Be a radiculopathy with motor neuropathy.
Yeah, that's a possible. Radicular neuropathy, that's a perfectly possible. Something like a CAD. That is why they did this thing in the electrophoresis and all. Because of the FAB is also prolonged. That can occur with the radiculopathy, but the conduction velocity is prolonged, but not much prolongation conduction velocity, borderline. Okay, they found a heavy chain abnormality there, monoclonal gammopathy. Then this is the final, that's immunofixation. Myeloma band detected, IgG band positive, kappa band positive. Okay, this is the IgG level, immunofixation. Okay, so it's monoclonal gammopathy. So what do you want now? Bone marrow?
MRI again to
contrast.
Okay, right. So anyway, MRI, brainstem peripheral smear was done. That is normal. Bone marrow aspiration was done. We showed 7 to 8% of plasma cells. No evidence of any plasma cytome. So that M band, how far its significance, we do not know. There may be monoclonal gammopathy fund. So MGUS is possible, but that does not suggest multiple myeloma. Okay, different biopsy showing erythroid hyperplasia, no increase in the plasma cells seen. Now, what is your diagnosis? Now, what do you want me to do?
MRI again.
CSF
MRI.
and
Study.
CSF
But
analysis. CSF.
before that, don't you want a proper MRI done? Because, okay, let's see. Now, let's see what are the points against motor CADP. That's you have to tell first. Why not motor CADP? See, why no, it's not a myeloma, I agreed. So what? Why can't we motor CADP?
Upper limb is completely.
Pardon?
Sensory level.
Upper limb is completely.
Correct. Yeah, that's the point. It's got a CADP can be confined only to the lower limb, entirely. But a great syrup of the lower limb and this upper limb spread, as Feroz is telling, is sleeps what? Seems little less likely, illogical. Similarly, it's got something like a sensory level in the lower. Again, that makes very unusual for a motor CADP.
What does this sensory level mean? You said it's not the it's not in the cord because in the mid thigh. What does this sensory level mean?
What I meant was that suppose there is a radiculopathy part. You expect, or in a radicular neuropathy, expect sensory level to be in the form of peripheral neuropathy type. Here it is going up to something like a cord lesion, going up to the L1 level. For a cord,
it's not the cord. No, you said the sensory level is not because of the cord.
No, that I did not say. It could be. I'll come to that point later on. Okay. It could be due to the cord lesion. Nothing against. A cord lesion in the cervical also can produce a sensory level in the mid-thigh. It may only ascend up gradually. That's nothing against a cord lesion produces a sensory level.
But when I said the cord, you said it's not cord.
No, not the sensory. I'm talking about the weakness. The weakness part. Weakness has got a wasting, absent reflexes, everything, such an element finding. Cord plus this thing agreed. You understood, Jai?
Yes, yes.
Okay. Now, what are the points again is motor CADP, which I already said. Gate syrup or of all muscles lower limb with a reflexia, no weakness upper limb, as far as I was telling. Another thing is a positive waivers in. Again, little odd, no? Confined only to the lower. See, nerve affection is the upper part and lower part is again with intercostal nerves, no? So the lower intercostal nerves alone is affected, upper totally spread again is little odd. That it all points to some level, right? I already said some level. The level may be in the multiple root level or at the level of a segmental level or the cord level. Segmental level means, say, epiconus means L1 level. Conus means S3 level. Cord means the pyramidal level everywhere, as you all know, the usual level. So, what investigation you need?
Repeat MRI to rule out vertebral lesion, plasmacytosis.
Right. Very good. So, MRI was done. Did you see something? There is a compression of the cord at that's a D6, D7 level. I'll show the axial cut. This is the D4, D5. That is, see the extramedullary compression there. There is a tumor there. Contrast I will show you later on. The CSF is smudged out. Then the cord is shifted to one side. Again, you can find the shift to the cord.
What
That
MRI was taken previously? It was a complete cord.
MRI whole spine screening.
And didn't show this?
Pardon?
And that didn't show this, sir?
No, that I know. If you take a whole spine MRI, you can easily miss that lesion. So only one cut may be there, no?
Yeah.
That's all. Yeah, always MRI is spinal cord meticulous study has to be done. Okay, this is the MRI now. Show the evidence subsequently. So what else you need? Contrast. Contrast was this is the contrast. So it's many pictures as if a meningioma compressing from behind.
But so, this wouldn't explain the findings, because everything is LMN and this is
exactly. So that's my next question. This is extramedullary compression. So seeing that a compression, you should not jump into the conclusion that it is causing everything. Okay. No, so what will you do is surgery for meningioma? You can do, of course, you can do surgery. Nothing is saying you have to do a surgery, tumor is compressing the cord.
What about CSF study?
CSF was not done.
MRI of the cordas, MRI with contrast of the corda equalized.
Okay, MRI contrast was done here also.
At the lower level, sir, the corda equalization. At the level of the
that contrast was done. In fact, I did not show because that is only showing the cord.
For surgery, biopsy.
Yeah, biopsy we can do. No, but the question is, as what Joy is asking, the thing is that
NCS, sir.
Element cannot be explained.
NCS was already, now we repeat NCS. Okay.
Repeat the NCS, sir.
Right. That's a good thing to find out. Repeat NCS, that's to be done. Okay, before that, let us.
without any anti-Honsel involvements.
You can do anti-Honsel to find out element lesion, but see whether it's a chorda equina or anti-Honsel, everything is going to show denervation. So you can document that there's element lesion there. That's a good point. But clinically also there is ample evidence of an element lesion, got a wasting of the thigh, absent reflexes. But because you don't expect a cord lesion there to produce hyperreflexia and hypotonia even after 2 years. Very odd. So now let us analyze the problem. How to explain the absent reflex in the lower limb and absence spasticity with the cord lesion there? You cannot. So you cannot think of a persistent spinal shock.
Severe element lesion.
Yeah. So let us analyze the motor weakness of the lower limb. So where how far is the cord lesion causing the motor weakness? Let us see. First, is it concluding? Is it element UMN? Seems element because hypertonia and absent reflexes. Anything odd? If you think the whole weakness is due to element, is there anything odd?
No wasting.
Correct. No, wasting was the thigh is there. Wasting of the calf is not there.
Yeah.
So yes, wasting of the anterior thigh, but no wasting of the calf and anterior compartment. So you may argue that element lesion may not produce wasting, but in a person of 2 years and with zero power, you can't think of with zero power without any wasting. So this seems odd for an element lesion. So you think it's a combination, correct? Human plus element.
Yes, sir.
So both angle jacks are absent again. Again, more likely to element. My question is the neurofibroma, meningioma incident? That's also you have to think. Maybe they're unrelated, so what?
The sensory can be due to that one, no, sir?
Yeah, since even motor also can be due to that. A chordaecanal lesion or epiconus lesion also can produce the same, say, conus epiconus lesion or chordaecan also can produce the same thing, like a meningeal lesion.
Sensory is like a level, no, sir. Sensory is like a level.
That even see, level indicates only sensory, up to that level is affected. That need not indicate that a pyramidal tract level. It can be segment level also. Suppose you've got a chordaecan lesion extending up to the L2, the sensory loss will be from that level downward, will be there.
In that case, like say if it is an element thing,
yeah.
So, if it is like a neuropathy, the sensory level should be like a neuropathy, no? It may not be.
No, not like that. In intramural lesion, they grow longitudinally. Okay, they can cut off the crossing fibers, the root and tree zone, or even complete the tract sideways. Anyway, you can put a sensory loss.
That's right, but here there is no intramedullary lesion, no? It is extramedullary, extradural, no? Compression.
Yeah, intramedullary lesion is not that. That's the first question.
There's significant compression also.
There's a compression.
Compression is also there. That's my question. So that's why this case has been brought. Okay. So here's basically. So is it element or human both?
It is
or
both.
Human element? Both.
It is both. Looks like both.
Yeah, both. Correct. So what is evidence of a human now?
No wasting of the calf and the
only the absence of wasting of this thing. That's one point. Only that point. Okay, let us see. Maybe extensive chordaecanal lesion or epiconus lesion. Because angle jacks. Overall, looking at impression was like an element. Okay, except with that waist happens service. Okay.
But we don't see anything in the MRI, so why do we go on telling epiconus and conus lesion?
Well, I did not say. I'm telling the possibilities.
Oh, okay. You are discussing without the MRI.
Without the MRI. I'm only showing the MRI. We can do epiconus lesion later on, that if necessary. But let us find out, we found a lesion in the dorsal cord, compressed in the dorsal cord. Can we explain everything? That's the first thing logically one should consider before sending to surgery. So you cannot explain everything. So I was wondering what all things can be explained by that. Suppose you do the surgery in this patient. You think that everything is related to the tumor. Why do you want to do the surgery? So you have to document that at least some of them are due to the compression of the cord due to the many tumor. Then only the surgery is going to benefit. Correct?
So bladder can be considered due to the meningioma lesions, bladder mild retention features.
That can occur due to either human cord lesion or due to the cord icona or whatever lesion can put his bladder in. So that cannot help to differentiate. No, let us see. But one point we said that it's not entirely element because of the absence of wasting. That's a good point. I agree. Take that point into consideration. Otherwise, no hard signs for a human till now. And now let us see this one. He has got a sensory level in the lower limbs up to the element level anterior. Is a sensory level due to radiculopathy, chordae equina, up to the element radiculopathy, or a segmental affection due to the epiconus lesion, if it is present. I'm only localizing. See, it's not, I'm not showing, discussing after the imaging.
Yes, possible, sir.
Possible. Okay. Everyone agrees with that? Okay, it is unlikely. I'll tell you the reason why. That is why I told you initially, this is a tricky case. But to keep watch on every finding which I have examined. He has got a normal vibration even over the sacrum and the L5 vertebra, but absent vibration over the knee, ankle, and the toes. How is that possible? With a chordae equina or a segmental lesion. How can it be possible with a radiculopathy with affection of L2 roots onwards, producing sensory loss in the anterior thigh and preserved sensory loss over the L4, L5 vertebra and sacrum? The same points argue against a corresponding segmental lesion. Okay. So the patient was re-examined once again. I wanted to know whether it's really bluffing. Just say yes or not. So examine. You see the examination.
Previous slide, sir.
No, the same. I'm showing another slide. Oh, you want to see this previous slide? Okay.
Yes, sir.
Okay. And the reason I will tell you now, because the subsequent video will show you why this point becomes relevant. Okay. See, this is the re-examination. He is not able to feel that side. Able to feel there. Yes. He said yes. There, the anterior part here is not able to feel, or the femur. Anticipation has been yes. Then subsequently I did was, then I started examining the pain sensation once again. Not feeling anywhere up to that level. No. He said no. Now he said yes. He said able to feel over that area. The buttocks area is able to feel. Illa. No. There he is able to feel. Except the perineal area, rest of the buttocks is able to feel the sensation. Okay, so look at the dermatomal supply of the gluteal region. See, this is the dermatome from the behind. See the you got sacrum, lower ligament. These are all these two L5S1. That area, all vibration is preserved. But in the lower limb, the other areas is affected. So how can you explain by radiculopathy? You cannot explain by radiculopathy. If it's radiculopathy or a segment affection there, element affection, I'm not a segment affection there, that should be involved all the dermatomal. Right? It's not fitting with a dermatomal pattern of sensory loss. You agree
Sir,
with
what
me?
was the perineal area? Perineal area sensation, what he told?
Perineal area is affected. That is, he's not able to feel. But on the buttocks area, which I have shown here, now this S2 and all, this area is affected. The surrounding area, this buttocks area where we sit, that area is totally sprayed. Over the sacral area, sensation is sprayed. The sacral bone. L5 vertebrae it is not. The thought came because he's got a level in the anterior part of the thigh. It's very clear about that. But posteriorly, the vibration, this is preserved. That is why I started examining the meticulously. So this will not occur with a radiculopathy or a segmented lesion. That is question number one. Then how will you explain?
In radiculopathy, all the parts of the radicle may not be involved, no? All the dermatome, the radicle may not be involved.
Okay, but all the radicals may not be affected, but the same radical effect can produce differential sensory loss, supplying the same area. See, one root is supplying two areas. One area alone cannot be affected. That area also can be affected. Some of the roots.
When we get an L5 radiculopathy, only the big toe may be affected, no?
Yeah, correct. But here, the sensory loss is up to the mid-thigh. Fiber is also lost up to the knee, the lower limb. But why the buttocks region is spared?
No, it's more proximal. That may be the reason.
No,
that's like the big toe. Big toe is affected and the other parts are not affected.
No.
Like
here
that.
only the problem here is from the L3 minimum L2 L3 segment downward is affected anteriorly. If it is due to root lesion, you expect the sensory loss to be there in the buttocks also. That is my point. The same segment of root is supplying that thing. The root value for the sensory nerve is same.
No, sir. When we get an L5 radiculopathy, we can get the sensory impairment only in the toe, no, big toe, no. So
yeah, that is early affection. That is early affection, correct? Only early affection. But is totally lost. Only one. See, root lesion and nerve lesion.
Not sufficient enough to cause sensations on the buttock region.
I'll tell you. I'll make it more clear to you. The point between a nerve lesion and a root lesion is that in a single radiculopathy, you may not get sensory loss at all because there may be overlap. Okay. But nerve lesion, it will fit in the distribution. Now, in a root lesion, why in the L5 radiculopathy, why it is only in the big toe? L5 radiculopathy is also supplying the dorsum. It is also supplying the lateral aspect of the calf. Why only that area is affected? Because the other surrounding roots is supplying the other area. So that is why, because the tremendous overlap of the dermatome with the adjoining roots, the sensory loss may be only confined to that. But this is not applicable if multiple roots are affected. See, there's no overlap. The other area which is overlapping is also affected.
Okay, sir.
Okay, that is what the point. Okay. So this tells you that, so the sensory loss does not correspond to dermatome. Severe affection L2 downward S1 square in the vertebra separated with the same roots. That's the argument. So, but you can explain by a cord lesion. Spinal cord compression or tract involvement can be patchy, as all you know. It may be need not confined to in a particular ascending pattern need not be there. Sorry, it may not confine to the stick pattern may not be there. So where is the lesion for the sensory loss? Most likely in the cord itself with incomplete effect on the sensory tracts. Superadded radiculopathy involvement may be there, but everything cannot be explained with that. That's my only point. Now let us see the objections for the spinal cord lesion at the site of the tumor at D7. Points against pure spinal cord lesion is, let's check the motor weakness. Most points are against, as you said, wasting of the thigh, hypotonia, absent DTR. One point favoring the additional pyramidal sign is the grade 0 for the calf and anterior compartment without wasting. Okay. That means that his weakness is not due to an entire element. Okay. And the sensory loss cannot be explained by the entire so-called element, not element, roots of segmental affection. So the point number one. So once you see why I'm arguing for there is something that the neurofibroma enzyme is causing, not entirely element. That is not an innocuous thing. That's my argument. So you need surgery for whatever birth it is, but we are not improve. That's the argument is that It's not entirely LMN. It's got some correlation also. Okay, now how to sort out the issue now? We want to know which are areas are human, which are areas you have to confirm it. So I did an EMG, I'll tell you, and subsequent NCS also will show. When I insert the needle, there is a good insertion activity. That means I am pricking into the muscle, not fibrous tissue. But you have no potential. Only positive, few positive waves, but no potentials. No motor unit potential also on activity. Then I checked from the calf. Let us see the calf now. Again, you can see the sound. Ready? See the good insertion activity and positive sharp waves. No motor unit. You got the point. Suppose it's a purely LMN. LMN, how can you have without any motor unit at all? What can occur with the human because of the poor activation?
Because it's gate zero power, no? So it's gate zero power.
That's the point. Gate zero power due to LMN. Imagine LMN. That means there's no muscle at all. In that case, we will not get the insertional activity also. Here, if you put needle into a muscle, you can get a burst of activity, the injury potentials that produce insertional activity. That occurs only when the muscle is there. But that should have put at least some power, some motor unit. It was not there. That's an indirect indication that he has got a poor activation. It means that human, you won't get any potential. It's paralyzed due to human lesion. Impulse is not coming down. But you can the insertion activity will be good. Muscle is intact. That's one evidence. Okay, let us see. So there is a good insertion activity, shows the muscle is there, not totally atrophied. Not even a single motor unit in activation. Even after more than 1 year, he has retained muscle mass with gate zero power, but no motor unit activation. That is suggestive of an human paralysis. Additional element is there. I'm not telling everything is element. Yes, pyramidal lesion as well, causing absence of potential due to poor activation. If there is a pure element, you would have got at least some MUPs with retained muscle mass. What is the retained muscle mass? Good insertion activity. So somebody asked for NCS, it was done. That's got a very valid point. I will tell you later on. Now, let us see. See, this is NCS which I have done now. EDB, no response. TBL AH, no response. But look at the TA peroneal amplitude, normal. TBL gastroembolic, normal. Femoral amplitude, normal. So what does it tell you? He's got a human lesion.
Human lesion.
Okay. So he has got evidence of, say, distal muscle, say, weak. So let it be weak, so what? But it's
human plus element, no? Because it's not.
Correct. So that means his weakness is there. So even though clinically you thought element, he has got a significant human paralysis to the lower limb. He got a element plus human. What is entirely said is correct. Now, these are the evidence I'm pointing to that. Initially thought element, this is the thing evidence pointing to that. And sensory potential repeatedly again absent. Tells it is not a neuropathy, it is likely to be proximal, maybe cardiac or somewhere else, or proximally, or maybe in the cordons. And FAF is totally inelicitable. Again, maybe due to proximal lesion. Right? Now, what else you want now?
Sensory was normal?
I didn't understand that previous NCS findings, sir.
Please ask me, I'll tell you. This NCS finding, see what you've observed here. Yes, are you able to see the motor NCS?
Yes, sir. Yes, sir.
See, there is no potential spectra from the extensor digitorum brevis. Okay? That means that is element. That's muscle is atrophied, element. Axon is affected there. But potential spectra from the tibialis anterior. Okay? That means if he has got a weakness of the dorsiflexion is 0. Tibialis anterior is good power. At least some power is there. But why should produce a 0 power? That means that dorsiflexion weakness is not due to element alone. because amplitude is good. 0 power cannot. Similarly, you take the gastrocnemius. Gastrocnemius amplitude is normal, but he has got a 0 power for the plantar flexion. Okay, so how can
Yes,
it
sir.
possible? If it is with a total element palsy, you won't get a potential. Producing paralysis, you won't get a potential, but your potential is present. You understand that logic? Yeah,
Yes, sir.
that is
Yes, sir. But left peroneal EDB and peroneal EDB and tibial
hallucis
is not
affect.
stimulatable,
Yeah,
but proximal is stimulatable, sir.
correct. Why that is not stimulated? That means that that muscle may be atrophied or that terminal part of the axon may be lost. Like a distal peripheral neuropathy, may be diabetic, where only the distal.
Is it a component of neuropathy, sir?
Yeah, that's a component neuropathy. Correct. What you said is correct. There is a component neuropathy. But
Okay,
our problem is disability. Neuropathy may be there, but what is causing is weakness. That's our problem. It has come with weakness.
Yes, yes, sir.
That particular wasting of the EDB and the autism is not going to cause anything to him. Okay, sensory potentials are normal. Okay, FA is not elicitable. Now, what
For
else
this
you
much
want?
of sensory
Because
loss,
of
how snaps are normal, sir?
That's what I said. If sensory loss is there, if snap is preserved, mean the lesion is proximal to the ganglion, sensory ganglion. Yeah. So it may be in the root or maybe in the tracts. Okay. The spinal cord lesion also sensory snap will be normal. In the roots may be normal. Even the central part of the cord also it can be normal. Any lesion proximal to that can be preserved.
So the etiology is most probably either so the etiology is less restricted to only the disorders which affect the dorsal root ganglion also lesser in addition to
No, if the dorsal root ganglion is affected, snap will be absent. Dorsal ganglion is the one, the cell body for the peripheral axon, sensory axon. So if DRG is affected, snap will be absent.
Okay, sir. Okay, sir.
Yeah.
So the GA and TA pickup, TA is showing normal CMAPs.
No, almost normal. Yeah.
It may be due to a proximal demyelination also, sir.
Yeah, proximal demyelination is possible. Agreed that what is correct.
Need not be due to in the cord, no? It may be in
need not necessarily be in the cord. Need not necessarily be in that cord. Right. What you said is correct. Okay. Right. So HR plus was done. That is also not elicitable. Okay. Right. Now let's analyze the motor system. Now this is the same point which I already told. See, this is the one the doctor has already clarified. His CMAP pickup from the gastrocnemius and diabetes is normal with grade 0 power. The femoral CMAP pickup from the quadriceps is normal with grade 0 power, showing that lesion was not in the lower motor neuron alone to cause weakness. Okay. Now, regarding Farah's question, he's got the lesion may be preganglion to cause demyelination or a motor. This thing has, but its amplitude is also low. Motor amplitude also low in certain nerves. But our problem is what is causing is entire weakness and so you have to think of a demyelinating lesion with a cord compression. That's possible.
Yeah, proximal lesion like Kimura was telling them.
Yeah, just like what I said, there is a demyelinating lesion proximally, like a CASP-like phenomenon, proximal root and proximal to the dorsal root, and axon they're affected by demyelinating lesion can produce the same. But he has got a denervation potentials from the limbs also. Not only pure demyelination. Okay, now what about his bladder now? Is it LM and UMN? Both are possible, correct? Correlation is there, there may be lesion in the caudicana or the segment may be there. So what else like to do? So I did a re-examine again. Does found have lax anal sphincter and absent anal reflex. Okay. Now, how to sort out the whole issue? She has got some muscles are in the lower limb, has got associated element finding that may be demyelinating type, proximal demyelination, or due to some structural pathology in the chordae that also can produce patchy involvement. Okay, but a demyelinated neuropathy hardly ever produces a perianal loss, and anal sphincter loss is seldom affected in a CAT, very, very rare. So a demyelinating neuropathy is extremely very rare in this period. We need not consider. A chordae lesion agreed, or some other epiconus lesion is agreed in addition to the cord compression. So cord compression is there, but something else is there. Okay, that we have to investigate. Now, his mass lesion is definitely contributing to the weakness of the lower limbs as well as sensory loss. Why? Because as told before, sensory loss cannot be explained by the roots and segment, because the point already told you the gluteal sensations were normal in the presence of an absent in the anterior up to anterior thigh. The motor weakness cannot be explained by electrophysiology. Also, again, I pointed out to you that by the NCS and the EMG, that is got potential with zero power. That means it's not element also. So the most, however, the most features are element because of the wasting of the thigh, areflexia, absent anal reflex, and patellar sphincter. So he has got both pyramidal and element. Now you all agree with that. Now, where is the element? Is it chordae or in the segment? Not obviously not in the peripheral nerves because nerves are normal. And he has got perianal, anal sphincter is affected. That means unlikely to be a peripheral nerve. So it can be in the roots, possible. Can be in the epiconus corners region, that's also possible. Now you agree with me, these two possibilities?
Yes, sir.
Yes. So what do you want me to do now?
Would it be a tractopathy or something, sir?
No, it's not a tractopathy. See, it's affecting that whole segments are affected. No, here, not only that, only the sensory tract is affected. Motor weakness is there, sensory tract is there. All they confined to that particular area. The bladder is also affected.
No, sir. The motor may be due to the compression, whereas the sensory thing is due to some tractopathy.
Or bladder, element bladder.
Bladder element, it may be due to human also. The compression can explain that.
He has got absent anal reflex and lax sphincter. That's why I checked all these things. Okay, now what do you want to do?
We want to do a contrast MRI of the lumbosacral lesions.
Right. Contrast MRI of the chordae was normal. Then what will you do? That is done initially.
Dedicated study of the epiconus region.
Very good. So what is, see, this is the thing I think I want you to keep in mind. The initial MRI appeared normal. I'll show the MRI. Looked normal. But you have to go and tell the radiologist, I want a special cut for including diffusion study for the lower this thing, because the meningioma is there that can compromise the lower part of the cord, either by ischemia or a venous congestion or something else can occur. But anyway, you have to document whether it is the lesion in the cord, conus epiconus, or in the chordae. For that, you have to do. First I did this thing. If it was normal, I am planning to do a CSF study and a CSF study and etc. I will be doing it later on. So this is the, see, did you see something there in the cord? Long hyperintensity from the tumor downward. Subsequent, this all this you can make out the abnormality there. Did you see that hyperintensity?
Yes, sir. Yes, sir. Yes, sir.
Yeah, I'll show the other film. See this one. Hyperintensity within the cord. This is again adjusting the window. You can easily make out between the lesion and the surrounding cord. See that one?
Yes, sir.
It is extensive from the tumor downwards. It is there. It is not present above the tumor. And the axial cut I will show now. The hyperintensity. See the hyperintensity within the cord. that is the epiconus region. See, that's not conus, you can the hypernecity within that thing. Okay. I'll show the zoomed up view. This is hypernecity within the cord. I'll see, bring it down. See the entire, see that is hypernecity, you can make out the cord. That is epiconus conus region. I'll show once again. See the hypernecity within the cord. And this is the tumor compressing that thing. And from that level onward is hypernecity. But the compression is not gross. It is not the opposite CSS space can be seen. It is of course compressed halfway through. It was Bichu's voice. I always discuss cases with him. So this is the, you can see the cord partially compressed. Still you can see CSS space on the opposite side. So the patient has another intramedullary pathology at epiconus in addition to the cord component D7. A single pathology cannot explain the whole clinical picture. The tumor causing mainly paraparesis, sensory loss, and positive behavior sign. Wasting of the thigh, areflexia due to intramedullary pathology affecting the anterior horn cells partly, and the reflex carrying fibers within the cord, the epiconus region. Now, what is causing extensive this thing? Now the question is, what do you think the hyperdensity is there due to? Is it not syringe? It's not carried that it is not the intensity is not that of a syringe. T1 was not showing it.
Venous condition.
Yeah, that's the thing, but to keep in mind. So I discussed again with the radiologist. He kept the possibility one is dural AVF or a venous traces due to extramedullary tumor above, or some other ischemia, some causing that cause. That's one thing you have to keep in mind.
There's no there, no? There's no. Are you seeing any dural vessels?
Yeah, to find out, see about the dural AV fistula. Dural AV fistula can be missed by a normal MRI. Can be entirely normal in dural AV fistula. If you can see the vessels, if you see the vessels, you can well and good. Now
we look at in this picture.
Yeah, I'll tell you. So for that, you have to take a highly T2-weighted image, something like a C sequence. You know, you take a C sequence in the brain where the CSF pathology can be made out very clearly. So you look at the picture now, how T2-weighted it is. So it's all making black and white. The CSF is projected out. If you look very carefully, there is some vessel seen on the dorsal aspect, lower down here. But he said he's not very sure. So this is the thing, suspicious vessel there, you can see there. Some suspicious directed. So what do you want to do now? If it's a dual AV fistula, it's very good. If you block that, it will remarkably do well.
DSA? Spinal DSA.
Okay. So the patient spent a spinal angiogram, told DFA. I sent to Santosh Joseph, and he did a very good spinal angiogram. There was no dual AVF.
And you are sad.
So, what will you do now? Do surgery for the meningioma. Let us review the findings later on. So, he has undergone surgery yesterday. This case is still in the ward. So, presuming that there may be venous congestion causing that thing. So, you take out the tumor, probably then compromise may be there. We do not know exactly that will be the reason. But you have to, that is the approach what you have to do. See, if it's not improving, then you have to investigate further.
So you think radicals are not involved at all?
Roots are not affected. Everything is due to an intramedullary release. And now, how this can compromise? I think many people may not know this. So, you know, the artery of Adam cubic standard, I'll skip that thing. But you must know certain water zone. See, Adam cubic artery involvement sometimes can produce the entire conus can be sometimes affected. This is because the peculiar supply of the conus epiconus region that I will show you. But the water zone can be longitudinal. That is at the longitudinal, as you know, at the junction between the two adjacent zones spinal blood supply. That is cervical branches subclavian region cranially and the intersegmental branches usually at D4 level. The horizontal water section is between the sulcocommercial artery in the central part and the bile vessels from the outside, the circular arteries from the outside. Okay, now this is the one I want you to know, the pericornal anastomotic circle. Near the caudal extremity of the spinal cord, the antispinal artery gives two small lateral branches that curve sharply backward to reach the dorsal surface of the cornus medullaris and continue cranially as the lowest portion of the left and right posterior spinal arteries. What I'm trying to say is that antispinal artery coming down, from the antispinal artery, two branches curve backward and ascend as the posterior spinal artery. So if that artery is affected, there you can have both posterior and anterior part can be compromised. This is this artery they are talking about, coming from here and go backward. I'll show this picture shows much more clearly. The one which I'm pointing is the antispinal artery. Okay, from in front. This from behind. We are viewing from behind the cord. This gives us two branches, one here, one here. That forms the posterior spinal artery back in the back. These two are the posterior spinal arteries. So cranially, the posterior spinal artery is coming from above, and below it is coming from below. So the Adam-Gibbs artery is affected. You can have a water-tread zone in this region, epicornus region. So even a cranial compression can cause a ischemic zone lower down. Need not be there at that level. Because the water-tread zone, the classical water-tread zone, the D4 leaf level. That is because the cranial branch of the Adam-Gibbs and the descending antispinal artery is reaching there, the DF. Similarly, there is other water zone is in the epicornus region. That is because of this particular phenomena where the antispinal terminal branches ascend up and then the water zone is separated. I think, is it clear to you? The illustration depicts the circulation pattern with the spinal arteries. Note the anterior to posterior flow in the arcuate branches. This is the arcuate branch, what is shown here. And ascending flow within the lowest portion or the posterior lateral and posterior middle spinal arteries here. So here in the posterior spinal artery, it is going from below, from the other thing going from above. The dorsal watershed zone shaded area corresponds to the portion of the posterior spinal artery network located at junction between these ascending and descending flow patterns. And this is on the literature, how the watershed infarct can occur in the cornus epicornus region. So that is the story of the patient. So any questions?
Sir, suppose it was due to ischemia, we'll be expecting atrophy, no?
Atrophy, I mean the cord.
No, the muscles, no? There will be wasting, no?
That's what I said. It's not entirely eliminated. It's not entirely antecondylar is not. Entirely eliminated is not there. The thigh which is affected, that is the epicornus region, that is wasted. But the lower down, that antecondylar S1, L5, S1, that is not wasted. So some part is root caused by the pyramidal, some part is by the antecondylar loss. The relative contribution will decide whether wasting has occurred or not. Is it not a simple case, very tricky case?
So he also has his bone marrow aspiration also showed multiple myeloma.
That is totally unrelated because it's an NGUES. That is monoclonal gammopathy, unknown significance.
Only
See, some
7.
of them, only 7. More than 10 is only taken as far as I know, I do not know 100%.
More than 20.
More than 20, more than 20% is taken as significant.
Then why is the CMAP completely absent distally?
Pardon?
Why is the CMAP absent completely distally?
Joy, I didn't know what is absent?
CMAP amplitude, no? It's completely zero distally.
No, but probably he is maybe diabetic. That's why he's got a distal CMAP amplitude is lost. As told before, he has got a peripheral neuropathy also, motor peripheral neuropathy.
Okay, sir.
But that is not important because the weakness cannot be explained by that.
Very tricky case.
Great case.
Sir, MDUS has no relevance in this case then.
No relevance in this case. I spent 2 whole nights thinking about this case to explain this element finding, because the MRI initially done was reported normal. So I went and coaxed the radiologist. There is something there. You have to look and look. Then only he did other cuts. And our radiologist is so kind. We meticulously look for that, took the special cuts for that.
When did you start examining him in so detail in the lumbosacral region? Why did you decide?
Because when I examined him, when I saw the patient when I went to Kollam, then I asked him, say, I want to see you, get admitted and see you in detail. He came there, properly came to PRS hospital. Then I started examining detail. Then I started wondering why this cannot be explained that. Then only did the detailed examination. The perianal sensory loss all did on second, third day, not in the first day.
No, why did you? That's what I'm asking. Why did you think about examining there in detail?
Because it was not fitting with a cord compression above, nor fitting with an LML lesion below.
Okay, sir. Okay.
Because the wasting is not there, so the assembly weakness is there, NCS is not corroborating. So it's not fitting with the demyelinating pattern, even the same. That's the thing I went next time. Okay,
very nice,
so
very nice, very learning case, sir.
Yeah,
very
that's the only thing for the juniors. I will tell you, always no investigation can surpass clinical examination. So when you have got a doubt, go to the patient, examine again, you will get the answer. That's exactly what I initially what I've done here. Initially, I was not able to make a diagnosis. I told you I spent whole night thinking about this case, how to make the tails meet. Okay, any questions in this case before we close?
Sir, we had a similar case where there was both ligamentum flavum hypertrophy and cervical disc prolapse, but the presentation was exactly like this conus medullaris cauda equina. So can such proximal lesions, such proximal compressions also cause watershed ischemia in lower down in the cauda or the conus?
Yes, it can cause. It can cause. That is what
Okay,
I showed you, the blood supply. The blood supply here. See, a compression above that depends upon where the level is. Suppose if the lesion is upper dorsal and down, it will not cause a cauda equina because there is already getting supply from there. If it is in the adamcubic artery, after entering at D9 L1 level, it divides into an upper branch and a lower branch. The upper branch goes upward and connects with the descending antispinal artery. The border zone between that area is the upper watershed zone. That is the D4 level. The descending branch of adamcubics comes down and replenishes the antispinal artery. That area is compromised. You get this second watershed zone because of the posterior spinal artery is coming directly from the vertebral. That is coming the posterior part. Here, that posterior part also is ultimately supplied by the antispinal, forming that arterial loop, that periconal arterial loop or circle. So you can have a lesion lower down in a lesion. Suppose this compression is occurring at a low, let's say D10, D11 level, you can have ischemia lower down also.
Okay, sir. Thank you, sir.
So for this case, we did try to do a diffusion study to find out any infarct there, but that was spinal cord diffusion sometimes may not work. Did not pick up the picture was not clear.
Yeah, sir. In cauda equina region, there is no point in doing a spinal diffusion because there is clumping and.
No, not spinal cauda equina. Here the lesion is in the epiconus conus.
In the conus, sir, yes.
The spinal cord. The epiconus and conus are part of the spinal cord. There we are looking for the lesion is there, not in the cauda equina here. Lesion the segment. Segment that forms the cauda equina. Because as told before, a cauda equina lesion can be exactly made by lesion from the corresponding segment, that is the L4, L5, S1 segments. There we look for a diffusion restriction that is not there. Hyperintensity also there only. Okay, then shall we close?
Thank you, sir. Thank you, sir.
Good night. Good night. Good
Good
night.
night. Good night, sir.
Thank you, sir.
Thank you very much, sir.
Thank you. Thank you.
Thank you, sir.
Thank
you.
you. Thank you.
Sir.
Thank you. Thank you.
Right, sir.